I'm Taylor Thompson, a pulmonary critical care physician at Mass General Hospital, and I'll be taking you through a new definition of ARDS and reviewing some options for pharmacotherapy. These are my disclosures. So we'll cover two aspects of ARDS. First is reviewing the rationale for and the details of the Berlin definition, and I'd like to highlight two major changes from prior definitions. Clarification that the chest radiograph can show multifocal opacities and still be compatible with ARDS. And what might seem obvious but was not allowed in prior definitions, that ARDS may coexist with heart failure and left atrial hypertension. And then we'll go through some new data on pharmacologic therapy. This is a summary slide from a nice review by Michael Mathey showing that ARDS can result from a number of insults to the lung. Acute lung injury is accompanied by alveolar capillary membrane injury, inflammation, and the hallmark of the syndrome, a protein-rich pulmonary edema fluid born of the increased permeability. What we're increasingly realizing is that there are two trajectories of patients with ARDS. There's a rapid resolution clinical phenotype, if you will, and there are those that remain on the mechanical ventilator for quite some time, develop multiple organ failure, the most common cause of death in patients with ARDS, and they may go on to develop pulmonary vascular fibrosis or pulmonary fibrosis and vascular destruction. We'll be talking in this talk about some of the pharmacologic therapies that might influence a movement towards rapid resolution as opposed to persistence. ARDS is common, almost 200,000 cases per year, many deaths, and over 3.5 million hospital days. Of the various pulmonary insults that cause ARDS, pneumonia and septic shock is the risk factor in over 80%. This is the task force that convened in 2012 to create a new definition from ARDS for ARDS. I was one of the co-chairs, and we assembled a group of experts in Europe and Canada. Using a consensus process and a patient-level meta-analysis, we iteratively refined a definition, and this is what it looks like. First, timing, which has never been an explicit feature of prior definitions, is now part of the definition, and ARDS generally occurs within a week of one of the known clinical insults. If you have a patient with ARDS and they've been sick for 3 or 4 or 5 weeks, dry cough, progressive dyspnea, refractory to outpatient antibiotics, start thinking of interstitial lung disease, and that would be a most unusual presentation for ARDS. The vast majority of ARDS is apparent within 48 hours of a clinical insult, but rarely a week later. Bilateral opacities, not fully explained by effusion, lobar atelectasis, and nodules, and we'll drill down on that in just a moment. And then respiratory failure should not be fully explained by cardiac failure or fluid overload, but they may coexist. We also noted that if you do not have a risk factor for ARDS, if a patient develops what appears to be ARDS without a risk factor, we're recommending that echocardiography or other testing be done to rule out cardiogenic pulmonary edema. ARDS is now parsed into 3 subsets based on the PF ratio, and there is a minimal requirement for PEEP in the moderate and severe group or CPAP. Now, knowing that there's been confusion about qualifying radiographic opacities, and there's really no good biomarker to parse heart failure versus ARDS, we put together a series of consensus radiographs in the electronic supplement, as well as some case vignettes, and I'll take you through a couple of those to make these points. So here's the distribution of ARDS from the patient-level analysis of over 3,600 patients enrolled in randomized and observational trials. And mild ARDS makes up about 1/5 of all patients with ARDS, with a 20% mortality. Here are the 95% confidence bounds. as an aside, it's an interesting comment for us intensivists that we would call something mild that has a 27% mortality. The moderate group has a 32% mortality. These are the confidence bounds. And finally, the severe group with a PF less than 100 on 5 or more of PEEP has a mortality of 45%. Let's spend a little time on the radiographs. The radiographic criteria for ARDS is in this paragraph. Bilateral opacities must be consistent with edema. They can be mild, patchy, and asymmetric. Opacity should not be fully explained by effusions, pulmonary nodules or masses, or collapse. And let's go through some of the sample radiographs. Mercifully, I will not show all 12. We'll just do a couple of the more illustrative. So, examine this radiograph. And the question is this compatible with edema? And are these opacities not fully explained by mass, atelectasis, or effusion? And the answer is pretty straightforward. This is yes. This is a rather typical case of ARDS. What about this one? Do we have bilateral opacities consistent with edema, not fully explained by mass, atelectasis, or effusion? Well, here we have a patient with a huge amount of soft tissue. We have low lung volumes. We have this gradient suggesting we have overlying soft tissue and maybe a pleural effusion. This is a no. This is not consistent with the ARDS. Upper lung vasculature fairly well seen. So this would be a no. So here's one of the sample radiographs showing multifocal opacities. This is a rather typical chest X-ray for multilobar pneumonia. Would be quite classic for Streptococcus pneumoniae, perhaps even Legionella. And is this chest radiograph consistent with edema? Well, the first question is, are these opacities fully explained by mass, atelectasis, or effusion? The answer is no. And I think where we get confused on a radiograph like this is that this doesn't look like pulmonary edema, but these opacities are not explained by mass, atelectasis, or effusion. In fact, there's almost certainly regional edema in the areas of inflammation. So this is consistent with pulmonary edema. And this is a fairly common radiographic appearance for patients with ARDS. So this is a qualifying radiograph for the definition of ARDS. And finally, what about this one? Do we have bilateral opacities consistent with edema? I don't know about you, but this is a tough one. We again have a large patient with a lot of overlying soft tissue. We have low lung volumes. We have some opacities at each base. May or may not be due to atelectasis or an effusion. This was a radiograph that's just equivocal, and it acknowledges that there in some patients a chest radiograph is insufficient to identify bilateral opacities consistent with edema. The new definition does allow the use of a CT scanning if done for any reason to make the diagnosis of ARDS, and a CT scan here would be of great interest. So let's move on then to the assessment of left atrial hypertension. The Berlin ARDS definition shifts the focus from excluding patients with left atrial hypertension. Recall in the old definition, if you placed a pulmonary artery catheter and the wedge was over 18, you didn't have ARDS. The shift now excludes patients only with left atrial hypertension as the sole explanation for their syndrome. And why have we done this? Well, left atrial hypertension and ARDS frequently coexist. We'll take you through a case making that point. Left ventricular dysfunction is common in patients with sepsis, septic myocardial depression, or pre-existing ischemic heart disease. And the chest radiograph, BNP, and troponin cannot distinguish heart failure from ARDS. So for these reasons, we allow these two to coexist. However, there's no accepted standard for excluding left atrial hypertension as the sole cause. So we created some vignettes. And I'll take you through a few of these vignettes. So here's vignette 1. 53-year-old man presents to the ED with substernal chest pain and dyspnea of 2 hours duration. He's afebrile, tachypnic, bilateral rales. SATs are 100%, on 100%. Oxygen are 96%. That's oxygen by face mask, probably be nasal cannula, high flow now. EKG shows anterolateral ischemia, and the chest x-ray demonstrates pulmonary edema. You get a rapid troponin T assay back at 0.1, upper limit of normal 0.03. You get an emergent echocardiogram, perhaps do it yourself, and you see a diminished left ventricular function with a focal wall motion abnormality. An attempt at non-invasive fails and the patient becomes hemodynamically unstable. After intubation, the PF ratio on 0.6 is 230, so we have a qualifying PF. But what's missing in this narrative is any risk factor for ARDS. So this patient meets the hypoxemia and radiographic criteria for mild ARDS, PFs between 2 and 300. However, as I said before, no identifiable risk factor. And there's clear evidence for myocardial ischemia. So this is not ARDS. Let's do another vignette. 72-year-old man with a history of COPD and heart failure has a 4-day prodrome of fever, productive cough, chest pain, and dyspnea, which is worse when supine. In the ED, he's short of breath, febrile, in atrial fibrillation with a ventricular response of 140, hypotensive with a blood pressure of 90/60, satting 92% on a 50% face mask. Decreased breath sounds are noted at the right base, and diffuse rales and wheezes throughout the rest of the lung fields. The lactate's 5, EKG inverted T waves across the precordial leads, echo global reduction in LV function, chest x-ray hyperinflated lungs with a dense right lower lobe consolidation. So far, this is a pretty classic case of a patient with pneumonia and may have some pre-existing ischemic heart disease. Patient's given 2 liters of normal saline, transient increase in blood pressure, but requires intubation and norepinephrine for shock. Chest x-ray shows a right lower lobe opacity, a right pleural effusion, and evolving left-sided opacity. So interesting, this radiograph, which was focal when he presented after volume resuscitation, now has opacities in the contralateral lung. What could this be? This could be pulmonary edema from the 2 liters of normal saline and a reduced ejection fraction. It might also be the development of capillary leak and injury in the contralateral lung, complicating his pneumonia in the right lower lobe. It's impossible to know which is which. The CVP is 15 millimeters of mercury. The central venous SAT's 55, suggesting a low cardiac output. Arterial blood gas post-intubation reveals a PF that qualifies for moderate ARDS at 180 on an FiO2 of 0.6, and the troponin T is up. So it looks to me like we have community-acquired pneumonia complicated by shock and a type 2 NSTEMI, or type 2 myocardial infarction. So this is a common scenario. Patient meets oxygenation and radiographic criteria. Clearly, the patient has pneumonia and pre-existing left ventricular dysfunction. And as you know, troponin elevations are common in patients with septic shock. Troponin elevations may be seen in up to half of patients with septic shock. The evolution of bilateral opacities, as I just said, could be heart failure, but it also could be lung injury. So this does not exclude the patient from having ARDS. So this is ARDS, probably with a component of hydrostatic edema. And such a patient in the prior definition might have been excluded. So how is the new definition doing in practice? This is a recent publication in JAMA from the Lung Safe investigators. We gathered up investigators around the world and did a survey of ARDS epidemiology, and shown here are the survival probabilities for mild, moderate, and severe ARDS. And one again can see that that classification does indeed identify patients at high risk of death in the first month. One of the reasons I'm showing you these data are that in this international survey, between 51 and 79% of patients with ARDS were not recognized by clinicians as ARDS. They were recognized perhaps as having heart failure or perhaps as having pneumonia without ARDS. I've often wondered if confusion about the chest radiograph led to some under recognition. But since we do have therapies now for ARDS, we'll be reviewing some pharmacologic therapies in just a moment. And in a separate session, we'll be reviewing lung protective ventilation strategies. Failure to implement these strategies may result in poor outcomes. So the under-recognition of ARDS piece is key, and it's one of the reasons we just spent some time on the radiographs and the clinical vignettes. Now, one of the reasons we have this definition, which is really quite nonspecific, is that there is no troponin of the lung. And I'm showing you this laundry list of potential candidates that have been examined over the years, usually for an association with poor outcome. And none of these have operating characteristics necessary to serve as the, quote, troponin of the lung, lacking adequate sensitivity and specificity, both for mortality and discriminating between heart failure and ARDS. This is an active area of investigation, and stay tuned. I anticipate some breakthrough here relatively soon, perhaps with sampling of alveolar fluid with a mini-BAL technique. So let's move on then to pharmacologic therapy. For some of you listening today, you're probably going to say, wait a minute, I thought there was no pharmacologic therapy for ARDS. Well, there might be. In fact, there is. Here's a list of what has been tried: nitric oxide, surfactant, perfluorocarbon, prostaglandin E1 by aerosol, lysophilin, and so on and so forth, and none of these work. However, corticosteroids, furosemide, and cis-atracurium, neuromuscular blockade for 48 hours, have an evidence base that is that I would like to review with you and suggest there may be a place for some of these agents. That, of course, most of these have been tested in acute ARDS, that is to say where the opacities are mostly ground glass and the pathology is mostly DAD. Established ARDS, sort of arbitrarily defined as ARDS that has not resolved for over a week, has a more reticulonodular opacity, may have some macroscopic barotrauma, and has quite a cellular biopsy with DAD, that is to say diffuse alveolar damage with hyaline membranes, and an intense inflammatory response. And in this particular setting, both corticosteroids and GM-CSF have been tried, and neither have been proven to be effective, although I put the question mark here because there's some suggestive evidence for late in the course. I'm not going to review that here today, but corticosteroids given after 14 days of ARDS, so well into this organizational phase here, are probably harmful. So question for 7 to 14 days, harmful after 14. But I'm going to focus on what we know about these three agents. So let's start with furosemide. In order to do that, I'd like to set the stage by reviewing some physiology. These are some of the classics going back to 1959 by Guyton and Ken Brigham and Cirque Research back in '81, reviewed recently by the late Art Wheeler from Vanderbilt. So shown here is lung fluid wet to dry ratio. This is a measure of pulmonary edema. So you take an experimental lung that's freshly harvested, weigh it, then dry it. The difference is lung water. And shown here is left atrial pressure in sheep experiments. And as left atrial pressure is increased, eventually the lung floods. And it floods with this inflection point here, where we go from some modest increase in lung water to now florid pulmonary edema. But there's another part of the story. During this period down here, that is when left atrial pressures are between 0 and 20, the lung is responding to these high downstream pressures with an increase in lung lymph flow, shown here. And this is one of the compensatory mechanisms that helps the lung escape pulmonary edema with high downstream hydrostatic pressures. Well, if we superimpose this over here on this and then dilute plasma proteins with crystalloid resuscitation in this model, we shift this inflection point down here. So this would be a hypooncotic experimental setting. And this is fairly common. Crystalloid resuscitation is the dominant resuscitation fluid for septic shock, which is one of the major risk factors for ARDS. And we are creating this both dilutional hypoproteinemia and hypoproteinemia from third space protein loss in our patients. So our patients with sepsis or pneumonia with sepsis are vulnerable to developing pulmonary edema at lower hydrostatic pressures. And then if we add lung injury to that scenario where we increase permeability of the alveolar capillary and epithelial membrane, then patients can flood at very low left atrial pressures. Is this a problem? Well, in the 1,000 patient fluid and catheter treatment trial that we completed a number of years ago, where patients with ARDS were randomly assigned to a pulmonary artery catheter-guided fluid management strategy versus a central venous catheter. In the 500 patients randomized to pulmonary artery catheters, at the time of presentation, 29% already had a pulmonary artery occlusion capacity pressure over 18, and 35% had a central venous pressure over 12, vascular pressures that clearly put the lung at risk. This, as you probably know, is an area of intense interest for early resuscitation strategies that limit fluid administration, and those studies are ongoing or about to be launched. But at any rate, let's take a look at the data we have to deal with this problem. Well, the best data come from the fluid and catheter treatment trial. That's what FACT stands for. And this is a protocol for de-resuscitation of patients with ARDS once shock resolves. And the protocol is fairly straightforward. When shock-free, no maintenance fluids, diuretics to normalize central venous pressure until off the vent as tolerated for up to 7 days. And then diuretics were held in our trial for rising creatinine or an active urinary sediment. This was a 1,000 patient trial. Let's first look at the safety of diuresing patients with ARDS after shock resolves. And conservative fluids, that is active de-resuscitation, more adverse events of hypokalemia and metabolic alkalosis. No difference in new shock, 15% in each arm, or shock duration. So diuresing patients after shock reversal does not cause new shock, nor does it prolong shock should it return. No difference in renal failure. Interestingly, though, renal replacement therapy trended towards being less frequent, 10% in conservative versus 14% in the liberal arm. What about important clinical outcomes like survival and time on ventilation? This is shown here in this Kaplan-Meier distribution. This is the proportion of patients here. Shown here are the patients who are alive in the liberal strategy. And liberal strategy was usual care, essentially usual care fluid management, or at least fluid balance that mirrored usual care. And this is what happens when you're about 1 liter positive a day. And here is the survival for the conservative, the active de-resuscitation. And these differences are not different, trending towards favoring conservative, but a very weak trend, if any. However, there's something going on here with the breathing without assistance in the conservative strategy versus breathing without assistance in liberal. If we look at day 7, in those with a liberal fluid management with no de-resuscitation, 25% are free of mechanical ventilation, only 25%, whereas 40% are free of mechanical ventilation in the deresuscitation group. And this difference persists out to 60 days, suggesting that early fluid management is a disease-modifying intervention for patients with ARDS. If you want a number, you can take this one, 3.2 fewer days on vent in the survivors. So not a life or death decision, but certainly active deresuscitation has an important impact on the course of patients with ARDS. What about cis-atracurium? So this clinical trial by Laurent Papazian and the French investigators, published back in 2010, enrolled 150 patients with 340 patients with a PF ratio less than 150. So the moderate to severe end of the spectrum. All patients received low tidal volume ventilation. Both groups were deeply sedated, and they were randomized 1-to-1 to a cis-atracurium infusion. I want you to note that dose. That's a 15 milligram bolus and 37.5 milligrams an hour. Why was this dose chosen? Well, this was a randomized double-blind trial. Both patients were deeply sedated. Train of 4 measurements were not allowed, and the investigators wanted an effective dose well over 90% of the time so that there was no breakthrough neuromuscular function. So this is a high dose, and the 28-day mortality was reduced, and the 90-day mortality had a trend towards reduction favoring the cis-atracurium arm. And this phase 3 trial followed on 2 smaller phase 2 trials showing benefit. So there's some evidence that this may be an effective treatment. If it is, how does it work? Well, before we answer that question, let's look at an examination for heterogeneity of treatment effect. Shown here are the tertiles of PF ratio. A third of patients had a PF ratio over 120, and there is no MET benefit in that group. Those with a PF ratio less than 120, in the placebo, they have, as anticipated, a lower survival, higher mortality than the PF 120 group, and all the treatment effect is in the more severe 2 tertiles. Now, how might this drug work, if indeed it does work? This wonderful review by Art Slutsky that accompanied this publication in the New England some 7 years ago, Art hypothesizes that by reducing diaphragmatic contraction, we are reducing both volutrauma and atelectrauma, and that by reducing active expiration with the abdominal muscles, we're reducing the sort of end expiratory grunt, if you will, which reduces lung volume, causes lung collapse, and predisposes to atelectrauma. Well, if this is true, and both patients in this trial were deeply sedated, then even feeble diaphragmatic contraction is injurious. And if that's true, then the acutely injured lung, at least early in the course, is far more vulnerable to mechanical forces, at least than I imagined. However, there may be another mechanism of action for cis-atracurium, especially at this dose. Art Slutsky, again, with Finelli and co-workers in Toronto, in a rodent model of acute lung injury, found that cis-atracurium protected against ventilator-induced lung injury via anti-inflammatory properties. And the protective effect was not due to improved patient ventilator synchrony, or in this case, animal ventilator synchrony. So this suggests that perhaps cis-atracurium has a direct anti-inflammatory effect. If this is true, then the standard dosing, which is generally, let's say, 10 milligrams as a bolus and 6 to 8 milligrams or 10 milligrams an hour, depending on train of 4, may be suboptimal for this anti-inflammatory effect. So there's some confusion about cis-atracurium, relatively small clinical trial, nominal p-values, some confusion over dose. So the PEDAL network, PEDAL stands for Prevention and Early Treatment of Acute Lung Injury. This is an NHLBI-funded network, has decided to try to repeat this study, or is repeating this study. These are the inclusion criteria, very similar to the Papazian trial, and it's using the Accurus or the Papazian dose. So this large 1,408 patient trial will answer the question of whether cisatracurium is effective for patients with moderate to severe ARDS. It will not settle the dose issue. These investigators have chosen to answer one question at a time. Let's finish up then with a discussion of corticosteroids. Yes, corticosteroids are still being discussed for treatment of ARDS. There have been a number of contemporary meta-analyses that come to the same conclusion, and that conclusion is there is some evidence of effect. So here's one of these. This is from Peters in the British Medical Journal some years ago. Again, suggesting there's a trend, although in this analysis the confidence bound included 1. But look at the sample sizes. Relatively small clinical trials. In another analysis by Ben Tang in Critical Care Medicine around the same time, they concluded that the use of low-dose corticosteroids was associated with improved mortality, but there's a lot of heterogeneity of treatment effect, or heterogeneity within the studies. Sample sizes are small, and they called for an adequately powered randomized trial to demonstrate once and for all a mortality benefit or not. Now recently, Umberto Meduri in Intensive Care Medicine conducted a patient-level meta-analysis, and here are the sample size in the patient-level meta-analysis, and here are the survival distributions. And the probability of survival for those who receive corticosteroids versus control is higher, as is those randomized before day 14 of ARDS. The overall effect size is significant, does not include 1. And there again is some heterogeneity. So we have patient-level meta-analysis suggesting benefit if started before day 14. Study-level meta-analyses suggestive but not definitive. We clearly need better data. However, there's another line of evidence that's suggesting there may be a beneficial role of corticosteroids for ARDS, and that comes from the data on corticosteroid therapy for patients with community-acquired pneumonia. Number of trials, again, relatively small, although the Bloom study here is relatively large and was negative. For severe pneumonia, there seems to be an effect. For less severe pneumonia, not so much. The overall effect flirts with being significant. This was recently published in the Annals of Internal Medicine. So I think a cautious interpretation of these data is that there's no role for routine management or routine use of corticosteroids for patients with ARDS, although they appear to be safe. And for patients in the first few days of ARDS who are not responding quickly to lung protective ventilation and sensible fluid management, corticosteroids should be considered. A few words of caution. First, neuromuscular weakness following ARDS persists for years and interferes with activities of daily life and return to work. The role of corticosteroids in this persistent weakness is unclear. There's evidence on both sides of that. Also, a word of caution, at least in one observational study, steroids were associated with a doubling of mortality for severe H1N1. It's not clear if this is confounding by indication, meaning sicker patients receive steroids, or whether there actually is an adverse effect, but a word of caution there. Also, to make the point that ARDS is not a diagnosis, it's a syndrome, and we need to identify the risk factor leading to ARDS. Some syndromes that look just like ARDS are steroid responsive, and they're shown here: cryptogenic organizing pneumonia, acute eosinophilic pneumonia, and of course pneumocystis carinii, or now JCP, complicating HIV. These are steroid responsive lesions, and a good clinician, particularly absent an identifiable risk factor, should think about these steroid-responsive lesions. There is a limited role for biopsy and unresolving ARDS, and here are some references for you to examine there. So let's summarize. The Berlin definition clarifies that opacities on chest X-ray may not be diffuse. That is to say, multifocal opacities are consistent with ARDS if they're not fully explained by mass atelectasis or fusion. The Berlin definition also notes that ARDS may coexist with heart failure and gives some vignettes on how we were thinking about those patients. There's substantial under-recognition of ARDS with the Berlin definition, and the degree to which this is due to confusion about coexistent heart failure or multifocal opacities is currently under investigation. D, resuscitation after shock reversal shortens duration of mechanical ventilation. Lower doses of corticosteroids, and by that I mean less than 2 milligrams per kilogram of methylprednisolone per day, early in the course of ARDS and early in the course of severe pneumonia may improve short-term outcomes, but require further study, and they may be harmful in severe influenza, at least H1N1. And cisatracurium for early ARDS is promising, but requires validation in another randomized controlled trial. So that's all I had for you. Let's move on to a couple of multiple choice questions. Approximately how many adults develop ARDS per year in the United States? And as we just discussed, that's about 200,000, making this a bit more common than lung cancer and breast cancer. A 45-year-old with bacteremic pneumococcal pneumonia, shock, and ARDS is recovering by ICU day 2. You wish to use a conservative fluid management strategy and de-resuscitate this patient. The following are part of the ARDS network FACT approach. So A, no furosemide within 12 hours of vasopressor use. Well, you had to read the trial to know this because we didn't go over that in this discussion, but that is true. There's a 12-hour grace period for coming out of shock before de-resuscitation was started. Maintenance fluids were allowed during shock. If a fluid bolus was given for hypotension, furosemide should be held for 12 hours. That is true. Furosemide was held if creatinine was increasing and the urine sediment suggested tubular injury. That is also true. But if creatinine was allowed to rise to a maximum of 3 so long as the urinary sediment remained free of tubular injury. And then furosemide by continuous infusion was an acceptable alternative to intermittent dosing. That is also true. So the only false statement here is that maintenance fluids were allowed during shock. Maintenance fluids in this trial were banned in part because, at least in our view, there's no role for maintenance fluids in modern critical care therapeutics, with the perhaps exceptions of insulin-dependent diabetics who need a glucose source, and then perhaps those with forced diuresis or large insensible losses. Question 3, the Acarus trial, that's the Papazian trial of cisatracurium, suggests that cisatracurium may be beneficial during the first 2 days of severe ARDS in all patients meeting the Berlin definition of ARDS, that is everyone with a PF less than 300. A 15 milligram bolus was followed by 37.5 milligrams per hour, a very large dose. Or another trial is needed before cisatracurium at this dose can be recommended for routine management of ARDS. This is kind of a slam dunk. This is false. The apparent benefit, which of course needs to be confirmed, was seen in the PF ratio less than 120.